So this is a bit of a conversation, well, a one-way conversation between me and the camera, but I'm hoping that you will listen and have a think about what I have to say, maybe plant some seeds of thought. And I'd love to know your thoughts on this matter at the end. So as I've discussed in previous videos, the diagnostic criteria for PTSD and complex PTSD are quite rigid. In fact, they're really rigid. You have to meet that specific criteria. Otherwise, you don't get the diagnosis. While this rigidity may be appropriate in some cases, I believe it falls short of capturing the full complexity of trauma, especially in real-world clinical settings. The criteria do not adequately account for the comorbidity or the multifaceted nature of trauma, particularly in children or adults who were children who have experienced what might be known as relational or developmental trauma. And I'm not alone in this perspective. There's a growing body of professionals advocating for the recognition of developmental trauma as its own diagnostic category. So they're saying it should appear as its own entry in the DSM-5 or the later variants and the ICD-11 and the later variants. The argument is that PTSD, as initially conceptualized in the Western world, was derived largely from an adult perspective and was focused on single event traumas or studies that involved combat veterans. As a result, it fails to encompass the chronic, the multiple, the accumulative nature of attachment and relational trauma that children often experience during their critical developmental periods. For instance, trauma occurring during a child's sensitive developmental stages can lead to complex disruptions in affect, so emotion, sensory and physiological regulation, changes in attachment patterns, interference with developmental competencies, and deep-seated or deep-rooted feelings of ineffectiveness, of shame, and of self-blame. These critical aspects are not fully addressed within the PTSD criteria. And furthermore, there's concepts like moral injury, which is a significant aspect of trauma for many, many people, which aren't even considered at all. And there are many stressful experiences that massively affect development that aren't included in the PTSD diagnostic criterion Part A. And that Part A focuses on exposure to a traumatic event. So it tries to define a traumatic event. And if you aren't sure of the diagnostic criteria that I'm talking about, then check out the video I made that explains it. It goes through each of the criteria and what it means. And I see it in the comments. I see people saying that they meet all of the criteria apart from criterion A, and therefore don't meet the full diagnostic criteria and therefore can't access treatment pathways. Things that jump out that are excluded include caregiver separation, verbal abuse, bullying, chronic sibling conflict, multiple placement moves for children who are looked after by local authorities or need to live in temporary accommodation for whatever reason, and living with a caregiver or living with a parent who has their own mental health difficulties, so the child effectively becomes their carer. These omissions leave a significant gap in understanding and addressing the full scope of trauma. And the term PTSD also fails to consider the multi-layered aspects of trauma and the intersections with wider society, such as intergenerational trauma, historical trauma, cultural, community, organizational trauma, as well as factors like poverty, not having access to resources or basic needs, and social exclusion. These elements are crucial and they warrant acknowledgement, they warrant validation, and there needs to be appropriate support where needed. And let's just think about what PTSD actually stands for. Post-traumatic. Post meaning after, meaning the trauma has happened, it's in the past, which does not accurately reflect the experiences of children and adults whose trauma is still ongoing, it's continuous, and it's accumulating. And I can't help but feel giving it the description of a disorder medicalizes and pathologizes what is an adaptation to an experience or experiences. and it places the issue within the person, as if there is something wrong with them, rather than considering what has happened to them and the contextual factors around that. A lot of the behaviours we see in people who have experienced trauma are adaptive. They make sense. They aren't dysfunctional. They are typically survival responses trying to keep that person safe. And quite often, we see a wide range of diagnoses being given that focus on very behavioural symptoms rather than what might be underlying those responses. I certainly see this in my practice, where a person, say, using substances to help them cope with nightmares or intrusive thoughts, but it's the substances that becomes the focus of the intervention or the diagnosis, not the underlying trauma. Not the reason they are using substances in the first place. So what happens then is someone doesn't meet the criteria for a PTSD diagnosis because it is so inflexible. And then to access a treatment pathway, they need to be put into a diagnostic box. So it's quite often the wrong one. If we take a look at Alexandra Cook's research on complex trauma in children and adults, which is a seminal piece of work, she says, children exposed to maltreatment, family violence, or loss of their caregivers often meet diagnostic criteria from the DSM for depression, ADHD, oppositional defiant disorder, conduct disorder, anxiety disorders, eating disorders, sleeping disorders, communication disorders, separation anxiety disorder, and reactive attachment disorders. Each of these diagnoses captures a very limited aspect of the traumatized child's self-regulatory and relational impairments. That's not to say that every person who is diagnosed with one of those disorders have suffered trauma, but it's to say that we need to take a look at the underlying reason that they might be happening, instead of relying on a checklist of symptoms to see what label most likely applies. And quite often, the treatment plan is to address those symptoms and not the underlying cause, so it's questionable whether it helps anyway. Bessel van der Kolk also puts this very nicely when he says, the way we define their problems, our diagnosis will determine how we approach their care. Such patients typically receive 5 or 6 different unrelated diagnoses in the course of their psychiatric treatment. If their doctors focus on their mood swings, they will be defined as bipolar and prescribed lithium or valproate. If the professionals are most impressed with their despair, they will be told they are suffering from major depression and given antidepressants. If the doctors focus on their restlessness and their lack of attention, they may be categorized as ADHD and treated with Ritalin or other stimulants. And if the clinic staff happens to take a trauma history and the patient actually volunteers the relevant information, he or she might receive the diagnosis of PTSD. None of the diagnoses will be completely off the mark, and none of them will begin to meaningfully describe who these patients are and what they suffer from. So let me know what you think. Are the current diagnoses and criteria enough? Should it be more flexible? Should we have a separate diagnosis for the other types of trauma, like developmental trauma? What are your thoughts on this? I am genuinely interested. The people, the clients, the patients that I serve have a voice. It needs to be heard from clinicians like me. Take care, everyone. Goodbye.